All right, time. We're ready to start the report backs. And I decided to stand here because I was having trouble seeing where all the hands were when I was sitting there in the middle. So we have, if we can now stop the table discussions, and I hope these discussions are going to continue for the next 2 days, and have some report backs. We have about 20 minutes for that before our break. So who wants to start? Okay.
All right. Eugene Anderson with the American Dental Education Association. One of the things we touched on, one of the speakers talked about the importance of starting this not with residents but with the first year. But we also talked about it starts even before the first year with who you admit into the programs and really looking at what individuals bring and the experiences and what they can tell you about their commitment to serving diverse communities and the importance of that.
Okay. Next. Oh, you have more. Oh, you have more. Okay. Sorry, we have one more from this table, and then we'll move over.
So one of the things that came out in our discussion was the importance of changing the whole model of clinical education so that it is more truly longitudinal, because the kind of skills that we're talking about cannot be acquired on our classic rotational basis of training. So we need to think about experiences that are longitudinal and meaningful in the community, forming longer-term relationships with patients, families in the community, and longer-term relationships between learners and faculty.
Okay. Adding on. Go ahead.
So I'm glad we heard that comment because this builds very nicely on the theme of non-traditional ways beyond the clinical preceptorship or clinical rotation model. And two that we talked about, one is the Health Mentor Program that at the University of Toronto, I'm Maria Tassoni from the University of Toronto and the Canadian Collaborative, that we modeled on Jefferson University. We talked about the burden of clinical placements and the issues around demand and supply. And so having these longitudinal experiences where interprofessional groups of students go out into the community without the need for a clinical preceptor. They spend time with people who are living with chronic illness and chronic conditions, and the faculty time is when they come back for the debriefing as opposed to when they're out in the community. And that's one model that's been growing and might be applicable and relevant to other settings. And the other one we talked about was the student-run clinic. And so it's been amazing. Sarita mentioned it yesterday in her comments around global health, the Imagine Clinic in Toronto, student-led, growing, and wonderful non-traditional opportunity for students to engage in health education and health literacy beyond the clinical preceptorship model.
Okay. Anyone else from this table want to add on to that, or we'll just keep going? We can come back too. So who wants to be next? Go ahead.
Yeah, in our table, actually, we discussed, or we focused on several things, actually, the important role that the navigators are playing. And the navigators are there for the sake of the patient. If we are assuming that the patient is supposed to be the lead in the health system, actually, not just like the patient and somebody who will be informed about what he needs to do, we have to empower the patients, especially if they have like literacy issues, as it been mentioned. In addition to that, if this person is an immigrant, actually, it means that actually his level of education and his level of speaking English actually is not there at all. And the only access, he can only access English through an interpreter. So it will be like an extra burden to the patient. And for us, actually, like we have to know that United States of America or Northern America in general, absorbing right now also a number of immigrants from all over the world here to the United States. So this patient need to be empowered. And I'm coming from Maine, actually. I'm glad to be called myself a Mainer. Yes, Maine is not just a white state anymore, but we are there in Maine. So yes, and our role actually that we're playing is, first of all, yes, we work to empower the patients, but also we work with the providers who are already practicing, that have never seen an immigrant, never seen a patient from, for example, like Greater Lake of Africa, with their cultures, never seen an Iraqi patient before. These patients, they're coming to him. So the global health or the international health is coming towards your own town, not you have to go to them actually back over there, or you have to practice in international health department so that you can get access into these patients. And the most important thing that we are doing also, which is the third part, is we are helping the students to get this great interprofessional understanding of the concept of the patients actually that they're getting. And interprofessionals, actually, we are helping students to learn together. And to learn together, I mean that actually the nurses, the medical doctor, the physician assistants, the social health workers, they all work together actually in getting new information about the importance of cultural literacy, cultural humility to the patients.
Thank you. Yes?
Thank you. I am Liana Orsolini, and I work for Bon Secours Health System. We're a 6-state integrated health system with a School of Nursing and Radiology. What I learned from this table, and especially from Lual Mabur from Maine, is that you don't need, and I don't think it was an aha moment for me, we don't need to study global health to go overseas. We need to study global health to practice healthcare in the U.S., especially in Maine. I just, I don't know why it didn't hit me until you spoke, so thank you so much for being here. But it seems so obvious to me now. And, what we're doing is we're really by taking our students into the home and into the community, we are really deconstructing the current decontextualizing of our patients when we make them come to our offices, when we put them in a Johnny, which you told, and that opens up in the back, what we call a hospital gown, and so that we disrespect them. We put them in a one-size-fits-all unisex gown in a hospital bed. We strip them from their communities, from their friends, from their belongings, from their families, and going back into their lives in such a personal way really deconstructs the way we do business and puts the context back and I think the relevance back. And that's how we're going to really reach them. So thank you so much. This has been so enlightening for me.
Thank you. And I saw a hand up over here.
So hi, I'm Eric Hombo from the Accreditation Council of Graduate Medical Education, and I'm here to help. So we had some conversation here around accreditation, and I think it's an incredibly important issue and honestly a very difficult balancing act. By definition, accreditation for most of our professions is a professional self-regulatory process that has to rely mostly on professionalism and intrinsic motivation. Having said that, very helpful comments about how do we get the balance between process and structure requirements versus outcomes. The bet that the ACGME is placing right now is to predominantly focus on outcomes and describe what somebody's supposed to look like when they come out, and leave the kind of process and curricular elements to the programs to hopefully get them there. And so our job is to make sure we describe that well. Having said that, Zoe made a very important point. We had these milestones. She said, we're interpreting the milestones based on what we can afford, which is an incredibly powerful statement for me. And so I think the balance of trying to get in process requirements versus what we desire to see come out the end is always going to be a challenge. And I think this is a great group to continue to have that conversation about how to get that balance right. I fully agree with George Thibault, having studied the rotations that occur within internal medicine. They are incredibly dysfunctional. And yet we've made lots of assumptions that they're okay. They're not. And more of this longitudinality is something that accreditation had actually impeded because of process requirements requiring number of months, et cetera. And I think moving forward, getting that balance right is really going to be important.
Thank you. I don't see anyone who hasn't spoken yet, so Afa?
So just to build on that longitudinality and
Get a little
rotation-
closer to the mic.
Oh,
Yeah.
I'm trying to. Okay. Here I am. Afaf Milis. I think the question for us is how to impart a value system in our all our healthcare students. That's a value system about a social mission, and that we are all in it to really make a difference in patients' lives. How do we put in our curricula social justice and equity framework and operationalize it in a way that we model it ourselves? We model it with each other as team members without a hierarchy, and understanding each other's perspective and really modeling that to our students. So it's not only rotation, and it's not only longitudinal, and it's not only the kind of students we admit. It's all of those, but it's also all the 4 or 5 years that we have our students in nursing, medicine, pharmacy, social work, psychology, that we model that, and we put the entire curriculum within a framework of justice and equity for our society. And I just want to say something about global health. I would not scratch out global health from our curricula and just do it in Maine, because I think it's very important to do both. Developing countries are in our own backyard, and we should not forget that. But it's also important to be exposed to the rest of the world and not be ethnocentric and think only about our own country in education.
And we don't want other countries to pick up our bad habits. I saw a hand here first, and then 2 more, and then I'm going to have some closing comments, and we'll go to our break. So go ahead.
I'm John Finnegan. I'm Dean of the School of Public Health, University of Minnesota, and also board chair of ASPPH as well. So thank you for inviting people like me here as well. The discussion seems again to be a little bit more medico-centric, I think, than maybe the problem demands something a little broader than that. I recall a famous quote by Winston Churchill, which is that America will eventually do the best thing, but not, or the right thing, but not until it's tried everything else. And I think we're at a point here where we're realizing that whatever it is we've tried up to this point isn't working very well. The discussion this morning has been really good, but it's really about failed systems, isn't it? On almost every level. I am so glad there are people that have the capacity, willingness, and the heart and passion to do all of the things that we heard talked about here, but I'm deeply ashamed because it's a mark that our systems have failed utterly. And I think that's partly what you're hearing around here. We're training people in the health professions, not just medicine, but all the health professions, for a world that no longer exists, or that is at least rapidly going out of existence. So I think we still haven't really grappled with the issue of what that next system is. I think we're still tweaking around the edges, thinking that we can do incremental changes and things will get better and so forth. Now, I would argue that I think you need to go to some cross-cutting competency areas. IPAC certainly has helped out with that when we look at such things as leadership and systems and strategic directions and planning and those kinds of things when we look at diversity, professionalism, and so on. So I think there's guidance out there, but the really critical issue is we haven't yet grappled with what the system has to look like going forward in order to create that world that we're looking at. 2030 is going to be a world that will rapidly be a non-European descended world in this country, and it will be a world where the majority, or I guess almost 20% in this country, will be, over the age of 65, and there's a whole bunch of other things that I think come along with that. And we're trying to tie things back to the community, and personally, I think the old ideas were the best ideas, because this was an idea that came out of the 19th century. And it's one that deserves to be tried again in the 21st in our terms.
Well, it's not an accident. I used a quote from 1952 at the beginning. I have 2 more people, and then we will need to go to the break. I'll go ahead, and over here. It's a burning one. All right, 3 quick ones.
Heron Wolf, representing the National Academies practice from Samuel Merritt University School of Nursing. I envision, as we're talking today, how much of a paradigm shift we've been undergoing. In part, we have gone through the challenge of practicing on communities to now we're talking about practicing in communities. And what is the problem, from my perspective, and I think in our group we talked a little bit about it, we need to practice of the community. we have this disconnect, and that's one of the challenges. We can send students, quote, into the community, when in fact healthcare systems are of the community, if in fact we're going to do it right. And I think moving to a notion of health in all policies, we can talk about how much we spend in healthcare in this country by comparison to other countries. And we can also talk about the fact we've cut food stamps, and we can talk about we haven't invested in housing. And in fact, until we look at what does it mean to not send students into the community, but talk about our healthcare institutions, educational institutions being of the community, I think we're going to continue to have problems as a nation and in our health professions education.
Thank you. Okay, over here, and then the quick question back there.
Yeah, the learners do what they see more than what we tell them to do. And I think a key piece of this is to try to find a way, I think as John suggests, to get the deans and the health system directors to feel that this is their responsibility, because unless social accountability comes from the top with a passion, changes in curriculum, I think, don't do very much.
Okay. And
I've asked what would it take to instill certain values in our leaders and our students. Our question at the table here is, what if we selected for that? What if your admissions committees had half members from the community rather than all faculty and 1 or 2 community representatives? Those are things that you can change now with a lot of opportunity to make a difference.
Thank you. A lot of good points in this discussion. I think the comment about the fact that we're preparing students for a world that no longer exists is one that we have to keep in mind. The other one very much to keep in mind is that we have to model the behavior that we want to see at every level. And also, think back to that slide I showed you on the insider-outsider perspectives. Up to now, we've been mostly talking from the outsider perspective. We've been talking of people who are not of the community but want to do the right thing with the community. And a critical thing is learning how to get that insider perspective. And the example I started out with of Rich Carmona in Arizona, realizing that he wasn't going to affect health unless he went into the community, is one that we have to give all of our health profession students. I know I'm biased, I'm an anthropologist, but I find that taking people deeply into the community, let's go back to home visits, for example. Let's have people sit in community meetings, not as the authority, but as somebody listening. So as we continue this workshop, let's think about how, and accreditation is a key issue, but how with all of the conversations we're having, we give emerging health professionals, existing health professionals, and ourselves that experience of really being in and with the community and listening to the community. So with that, we have a break. It's roughly a half-hour break, but I am going to ask you to be back here and absolutely ready to go at 11:15, so come back a few minutes early, and we'll continue our conversation. Thank you.